Well, welcome to our February edition of our Val Lab chat series. We are still fireside bound because Lake Minnetonka still remains frozen. Though I have to say, given the very mild winter, at least Tom and I have enjoyed, it's surprising there's actually any ice left on that lake, though we did get snow recently. So in any case, we are pleased to welcome Lisa Simpson. She is the outgoing president, but still president of Academy Health, CEO. Lisa's been in that role for what, over a decade, I believe. So, or at least pretty
13
close to it.
years.
13 years, yes. Wow, that went quick. And I've gotten to know Lisa really well being on the board of Academy Health, which for those don't know is the preeminent organization of health services research in Washington, D.C., and had a huge influence in terms of different policy making. If you can imagine that 13 years encompassed things like the Affordable Care Act and other things as they were coming online, being debated, SCOTUS decisions held with bated breath, et cetera. This conversation, as you know, is recorded, so the first 30 minutes is on the record with Tom and I peppering some questions, and then we're going to go off the record from there. And so for those wondering, do I always dress up for this? No, but I'm teaching tonight and thought I'd make a good impression. But actually, I'm giving a midterm exam, so I'm not quite sure why I thought, doing this would be what I needed to do. Though I know, Tom, we've had conversations about AI. I found a way to combat it, at least address it, by giving an old school blue book exam.
My,
It's harder to have ChatGPT give you their answers in a closed book blue book exam. Sometimes the old things are reliable. So, Lisa, we sort of euphemistically entitled this the exit interview in a way. I'm not sure how many of these you've done before, but
I love it. It's great.
I figured if nothing else, there's so many things you've done along the way, but probably one of the first things is because our audience is mostly medtech entrepreneurs, students, not as many folks in the policy world, and even less actually sometimes the people in the research world. So the question out of the gate is one that you probably will appreciate because I know we've discussed this for years. Like, what did you think is the distinction between someone who does health services research and health policy research? And by all means, please pepper and you're a physician too, so by all means be as clinical as you need to be with us as
Oh,
well. So
yeah, no. So, I think that's, as you said, we've talked about this, and I think it's a point of discussion in our field. I tend to think about health policy research as a subset of health services research because health policy research is, in simplistic terms, and we can argue about this, it is health services research that is done to inform public policy, specifically federal or state public policy. That's not to say that policy doesn't happen in other settings, but to inform public policy. And so I see health policy research as really a subset of the broader, more diverse health services research community and field. And I mean, health services research is so broad. It encompasses like effective clinical effectiveness research, comparative effectiveness research, cost effectiveness research, outcomes research, improvement research, implementation research. I could go on. And in fact, this is maybe dated, but it's about I think close to a decade old when we did a survey of Academy Health members and asked like what kind of research do they do. They came up with 34 discrete terms to describe what they did.
wow.
And yet they're all health services researchers. So that's sort of, I see it as nested dolls that policy research is very focused. And I think also our field has historically been very much a federally driven policy research community. Going back to the days, I mean, we had cost of care studies and all that back in the 20s, but really back to the creation of Medicare and Medicaid when there was such government interest in care and its costs. But increasingly, I think we're seeing more and more state policy research and engagement in state policy, which is really important because so much is happening that is very relevant to healthcare at the state level. So our field has, I think, a tremendous opportunity to really continue to build on that state focus for its policy research.
And then a quick question, like what is I mean, there's a little bit of background. I joined, I think, the forerunner of Academy Health, which I think was the Association for Health Services Research way back when. I think for me, it would have been probably 1990, 1989. And I think the first meeting I went to was in San Diego and had maybe 350 people at it. And so, but now it has an annual meeting. And how many people, I mean, what's the membership now? I mean, it seems like it's grown, right?
Well, the membership has definitely grown. It dipped down during the pandemic. Well, we have both individual members and organizational members. So we're considered a hybrid membership organization. And so we have, depending on the time of year, because it's also linked to registration and things like that, around 3,000 individual members and about 160 organizational members. But at the annual research meeting, non-members also come because we have an audience at the research meeting. While it is very much a scientific sort of abstract, driven meeting, it is designed to also engage the research users. So we have discussants, we have policy roundtables, we have a broader dialogue about not just the the findings of our research, but also what it means for policy, for care delivery, et cetera. So yeah, we're up to about just the last couple of years at the annual research meeting, just under 3,000 people. So it's definitely big. And some, folks who've been in the field for a while say, oh, it's too big. I like the smaller meeting, but I think I see it as a sign of strength and growing. We welcome all. You don't need a certificate or a credential like to be a member of the American Academy of Pediatrics. I have to be a board certified pediatrician. So there's a very big difference.
Yeah, no, it's a great environment for that, and I think I'd really appreciate, because I mean you do have a situation where although it is big, the sessions themselves are relatively small. You
Yes.
get to really discuss some of the papers, and if nothing else, it's also a social interaction period as well. It is one of those situations where I could look to my own career. I could think of connections that I had at any of those meetings going back, I guess now over 30 years, gave me either a next contact, a next consulting contract, or a next job. I mean, actually, every W-2 job I had since working at Blue Cross came from a contact at one of those meetings. So
Right.
now that I think about it. Um, so I guess a few things other that are out there. I know we all dealt with COVID in a different way or not. And we're on the record, so you can be careful how you parse these things. But would you say in the end, this is sort of a little bit of a low question, like how did HSR in the end help, hinder, inform, move COVID? Because I mean, in some respects, like we all at some level are still public health researchers. We look at population health in some ways. We may have called it something different, but like this was our moment to shine,
Yeah.
right? And so how did we shine, in your
Yeah.
opinion, as the leader of us all?
Um, well, I think we shone in that people recognized they needed to hear from us. And so several of our members were regularly on television communicating about what was happening. Ashish Jha is probably, the most well-known poster
Right.
child for that statement, but many others. So our folks recognize the importance and information and value of what we bring to confronting a very urgent health challenge. I think the other thing that it's kind of more less what we brought to health to the pandemic, but what the pandemic has helped us to learn again, maybe, or realize we have to do better at, and that is communicating our findings. Trying to keep up with a shifting evidence base, changes that were happening at the local, state, and federal level all at the same time, and the importance of both mounting rapid response type studies, which is very challenging given that our field primarily depends on federal funding, some private sector funding certainly, but largely federal dollars. And so I think it pushed us to be more nimble and respond more quickly, and to focus more on how we communicate more effectively our findings to, again, policymakers, health system leaders, folks who can use it, public health agencies. So it's one of the reasons Academy Health launched in 2022 a new course called Communicating for Impact, because we really, there's a hunger actually among our members, like, how do I do this better? Because I
Yeah.
really saw where we fell short sometimes. I think the other thing that came up for many of us during the pandemic is, as it played out, was really the recognition of the role of trust and in our society and in healthcare and in research, and how trust was being frayed in so many different ways. Clinicians at risk every day serving patients. We just didn't know enough to protect many. And so I think, that's we're working with the ABIM Foundation on a research community on trust. If you're not a member, please join us if you're interested. It's about how do we do more research to understand how to build trust, the impact of trust being lost. I recently did an interview with Mark Schlesinger about a special issue on trust that came out in the Hastings Center report, and he did some really interesting work on the impact of a patient safety event on trust loss. And it's not just loss of trust in that clinician or that institution, it translates into loss of trust overall. So I think that's a whole area that we have, work to do in understanding better and fostering more trust. And then, I think the other thing that the pandemic certainly made me really confront and realize was how important it was to remember we might be researchers, policy wonks, talk about all this important big picture stuff. But in the end, we're all individuals and sort of it was a really challenging time. And I think as a community, we kind of came together to help each other through it. And that was very heartening. I think, we're a membership community. It's what nurtures my soul doing this job for 13 years is just the people in it. So some different observations, but I think COVID did create challenges for our field, and I think we did pretty well in some ways.
Yeah, I mean, there's certainly a lot of lessons learned, and probably thinking about whether to do it again, and certainly in terms of whether data or an access. I mean, I know one of the challenges and I was sort of more on front lines for like actually doing things. One of the bigger challenges was that there's the data that you can work with in a contemporary basis in the case of an emergency, and then there's data that's, it's too old to do anything with it,
Exactly.
and you couldn't. It might be useful to help frame the problem, but there were things that almost in my mind was like a parking lot. Like that's a great question. We're gonna look
Later.
at that later, but not right now. That's not an actual oriented thing. But there are also other things too that you didn't know until you were in it. Like if you actually want to try to see what's going on at a provider level, that's not the way our systems are developed. They're all built on payment, and to the point where they're so disaggregated by payment that you could not actually, or I should say aggregated, I meant to say, by payment. It was very hard to like disentangle where you could truly direct something.
Yeah. And just on that point in terms of health systems, I think I heard from many of our members who are researchers in health systems, whether it's Kaiser or, Mayo Clinic, Intermountain, et cetera, about how their health system leadership, really even more recognized the value of the work they were doing to their sort of corporate goals and health system goals. And so it was an opportunity for many of them to step up and shine and provide evidence much quicker than they had been called upon before. So,
Yeah.
Steve, let me interject here. I want to go back to something Lisa said that is kind of a head scratcher for me, and that is you were talking about trust and in the pandemic, and clearly we had lots of issues going one way or the other. From a research standpoint, from a database standpoint, are there studies that can be done that then give you action steps to get trust back to where some of us would say it belongs? Or is it, well, I'll leave it at that.
yeah, no, Tom, it's a great question, and I'll share sort of how I've been learning about this over the last couple of years because it's certainly not an area that I had any background in. And so we have two trust scholars in residence, Jody Platt at University of Michigan and Lauren Taylor at NYU. Oh, I'm going to forget the names of these systems changes so frequently I can't keep up. But and so they did a 50-year lit review of research on trust, and where we've done quite a bit of research on both what breaks trust and what builds trust is at the individual patient clinician level. So we have a better evidence base in that space. What we are not as good at is sort of clinician to organization. And with clinician burnout, there's a lot of mistrust and we're not sure how to rebuild that. That's an area where I think some studies are needed. Another area is between healthcare organizations and the communities they serve, particularly if those communities have been historically disenfranchised, marginalized, low income communities of color, there's already a long history of mistrust, and then the pandemic effects just deepened that. And there, I think we have more work to do to figure out how to build that, either build it for the first time if it never existed, or to build it back. But it brings up an important point, Tom, because I like the way you framed your question about action oriented. A lot of health services research, and this is Lisa characterizing it this way, the world according to Lisa, I get to say that now, right? Which is so much of our research over time has been describing the problem. I mean, the epidemiology of services, basically. Like, here are the challenges, here's who doesn't get high quality, safe, better care, at what cost, et cetera. We're really good at patterns. And part of that is we're a field that was built up over secondary data sets. So we can understand the sort of root causes of why we do that, but we really need to move into much more intervention research and, testing policy solutions. And that's why I think, for example, Kate Baker and Amy Finkelstein's study about the Oregon experiment was, they really capitalized on a moment in a policy choice where they could do something that is done too rarely in health policy. Actually, educational policy, juvenile justice policy, some other domains of policy use these sort of natural experiments much more than we do, I think. I mean, we're doing a lot of, regression discontinuity and all those, fancy methods I never use myself. But so does that kind of, Tom, get at what you're saying? I think we need to do more action research, and I think and that applies to trust, to health equity, you name the topic. We need more action research to show what does work at either a policy or systems level to improve whatever outcome you're seeking to improve.
Right. And I know Steve started with pandemic, but we know that the first pandemic in the last 100 years the next pandemic's around the corner, whatever it is. And it would help if we understood better how to get the messages down to the patient such that we could contain these.
Yeah. And because we're such a vast country, and Tom, you may not know that I spent 9 years at HHS in the federal government, 7 of those as the deputy director of the Agency for Healthcare Policy and Research, then became an Agency for Healthcare Research and Quality. And as critical as federal policy solutions are, a lot of the action and where the evidence was needed in the pandemic and will be needed in the future is at the state and local level. And we're such a big, very diverse country in so many aspects that I was really disappointed that our country did not mount that kind of, monitoring, surveillance type of study data capacity by policy units. I mean, a wonderful NCATS, the National COVID Cohort Collaborative, NC3 was built. PCORNet launched a lot of studies, but those were all based on clinical sort of patient cohorts, not units of analysis that are what decisions were made and when, and what difference did that make?
Yeah. Which is disturbing, because to a certain extent that data, those systems actually do exist now technically with the health IT infrastructure, but none of it links up in an emergency situation. I mean, this is actually a larger issue. I on the one hand, I'm an evangelical person as to what the value of the health IT systems are, but almost equally evangelical in frustration, and want to just in terms of saying, like, we have a national emergency. At least for data flow, there needs to be that the public health emergency takes a superseding basis. And it probably requires federal legislation to actually make this clear, because I don't think it's clear right now. Because for better or for worse, what became obvious in the pandemic, and no one really knew until it happened, was that the decisions for the public and safety rested at the states and the local municipalities. And no one had ever really thought about that in a modern age of everything being wired with hyper attentive news networks and everything else like that. Like, holy crap, the stuff that was basically in place for the Spanish flu is like the same infrastructure, and nobody is really trained to deal with it.
No, I'm
Yeah.
so glad you raised that because, in fact, we just published an updated public health service systems and services research agenda, another subset of our broader field. We've got a webinar about it this week, I think. Very much so. I remember at our Health Data Palooza, which is one of our annual events, um, state health departments saying they couldn't get any data themselves. They didn't have the data. They were calling CVS and Walgreens and trying to get data sources from all these industry partners, which was, I thought, very creative, and they were able to provide a lot of information. But yeah, the public health of all the sort of research data information infrastructures, public health has been
Yeah.
really underinvested in, is probably a polite way to say it. And we have an opportunity to change that. There's the data modernization initiative. I
Yeah.
hope we make progress this time.
Yeah. It's just to me still not obvious that there's probably a decent architecture for this, but you almost need to have something that goes through a switch that hits Epic, Athena Health, everybody else saying like, it's a pandemic now, de-identified extraction, where are we? For all decision making in terms of where things are. But
And Steve, just a note of caution,
yes,
data is power. And in some states, some data is being criminalized.
yeah, no,
So I think, and full disclosure, I'm on the National Academies of Sciences, Engineering, and Medicine Standing Committee on Reproductive Health, Equity, and Society. And the potential legal and privacy and security ramifications, not even to get into the health or death ramifications right now with EMTALA, the legal constructs
right.
being conflicted between national and state. So it is more complicated than I can really
No,
quite comprehend at this
I
point.
I hear you, and my physician wife, and I'm on the record, will also make she's a psychiatrist, she'll make the same comments about like that data can't go that broad and in a mental health capacity too, for same issues in terms of risk and things that go into that space as well.
Exactly. But
Um,
I'm an eternal optimist, and so I believe there's a way forward to figure that balance of responding to emergencies and sharing the data we can and should, and protecting individuals.
right, right. So this is a little bit of an extra interview, so I'm gonna try to throw a fun question back out at you. So given such a vast constituency, and I've seen you navigate quite a few things in the board for several years, and I gave you the preview of this question too. So if you were to describe what type of animal it is to herd for Academy Health, what is it? I mean, there's cats, there's dogs, there's rats, there's mongoose, flamingos.
You know what my answer is? It would
Yeah,
be all the animals on Noah's Ark, because our strength is also the greatest challenge, I think, for the CEO for this role. Our strength is we are diverse. We are diverse in disciplines, in types of research, in the data we use, and the methods we use. We're maybe not as diverse in perspectives as we should be about policy solutions, and we need to build that in for more diversity there. But when you're the president and CEO of an organization that represents all, sometimes coming to a way forward that meets at least most people's needs, and then
right.
recognizing unique needs. So it's both the fun of it, because you can be responsive, and that's one thing I've loved to see over the 13 years, is how individual members can walk up to me at the meeting and say, you should do this, Lisa, or whatever. I mean, Tom, I still remember, Steve, we were talking about the annual research meeting, one of the first ARMs after my CEO tenure started. And for those of you who don't know me, I'm short. I'm 5 foot. And Steve, you're how tall?
6'5".
6'5". Okay, so seeing the two of us in conversation is quite hilarious. But here we are talking at the reception, and Steve is telling me I need to have more health economists involved in leadership at Academy Health. I always remember that. I was like, we have a lot of economists, but
No, it's
but that's
true.
just an example of every stripe wants more of their stripe in leadership.
Yes, yes, and we got a few more in. It's okay. I mean, they talk. So this two-part question. We'll get the sad part first, or at least the grimmer part. So what, as a CEO in all these years, I mean, and it is a member organization. I mean, it's not relying on government grants per se or anything else like that. What kept you up at night in all these years of doing, or at least two or three things that would keep you constantly up, as it were? I know you sleep pretty well, but sometimes maybe not.
Yeah, no, it's a small nonprofit. You've got a, P&L statement to deal with every month with your board. You have the responsibility of making sure the budget works, of building the reserves, of responding to unforeseen risks. You try to foresee them as much as you can and future proof your strategy. But it's that constant, focus on, in a way, the bottom line, and that balance of, are you delivering on your mission and securing your future financially? And so you can imagine there were some definite sleepless nights during the pandemic, because a
Yeah.
big part of our sort of revenue stream, about 30% of it, is generated from our big events. And they all went virtual, and they still happened and people still registered, but not at the same level. And then we have liabilities on the books that 5 years out, we have a convention center that we have a contract with, so getting that trend. So all of those things. And the other thing that I think also happened during the pandemic that kept me up at night was just the number of decisions that were thrown at CEOs, people like me, of small nonprofits in health, that you had to act on to keep your staff safe
Yeah.
and informed, and feeling like we had their back, and maintaining the trust and transparency with our staff about what is happening and what we are doing about it. All of
Mhm.
that was a lot. That was a
Yeah.
lot.
Yeah, I actually feel a little bit of that too, because in the academic world, not quite to the same level, because we still had tuition, but there was still those moments where it's like they're not coming in class, and we have a lot of people where the in a business school, the reason why you charge $125,000 for an executive MBA, or now $130,000 here, is like you're coming in person to be educated, not to go virtual.
Right.
Um, so the fun part of it, what kept you going though? What gave you the hope to say like, nah, but or maybe it was the hope of retirement. But I mean,
Oh, I'm not retired. Remember, I said
no, the
stepping
hope of
down.
stepping down. I'm sorry. Sorry.
No,
And
um,
I don't mean just the pandemic. I mean, there are so many
no,
other
yeah,
things that
exactly. I think a lot of stuff kept me going. And Academy Health, like many organizations, has sort of an annual life cycle of things that happen predictably throughout the year. And so the lead up and build up to the annual research meeting was always exciting. And being at the meeting was just so nurturing. I'm pretty much an extrovert, though I do need to recharge my batteries. And being at the arm and seeing the vibrancy of our community, and the number of younger, we have like 25% students who are members. We
yeah.
love that. It keeps us fresh, I think, as a community. And the other thing that over the years I worked a lot on, and you've got to take risks, right? Or else you're not trying hard enough, I don't think. You're being too safe. And so we tried different kinds of partnerships, and one that, to this day continues, that I'm really proud of, and it was really exciting when we were getting it to happen, is the partnership with NIH for one of our other big events, the Conference on the Science of Dissemination and Implementation in Health, which has grown from, I mean, it was like a 300 or 400 person conference. We're now in the 15th or 16th year, and it's now,
Mm,
we were just under 1,400. So that community, thanks to NIH funding and lots of other
yeah.
reasons, I'm not taking credit for that, but that was, building those new partnerships was also a lot of source of feeling like I'd done something right. So that's another thing that was exciting. And then finally, I think the point about being the voice for Academy Health in Washington, the sort of the
Yeah.
advocacy, being able to, bring our members to the Hill, which most of the time now that's virtual. That has helped our ability to actually get members in front of, very key staff in both the House and Senate, and particularly we do a lot of appropriations work, but also authorizing work. And and then there's the advocacy with the executive branch for all the, policies and regulatory approaches, et cetera. So I feel like, we've we've had some successes there. You know, we've been able to have ARC's budget go up in recent years, and we got some language in the authorizing text for ARPA H, and we've built already a good
Hmm.
partnership with ARPA H, with that, which I think is a really important opportunity for the field. So those are some other areas that I feel that were exciting. I mean, it was a fun job. It is a fun job.
Tom, you want to close us out?
Um, I do, as we go into the second half, that'll be off the record, but I'm fascinated by analogies, sorry. So when you said your answer was Noah's Ark, I wonder if we take, and there are no perfect analogies, and I understand that I sometimes take them too far, but if we take Noah as a CEO and he's trying to herd all of these animals, you know, he's got predator prey issues. Okay, let's have a meeting over here. And we've got, you know, food and waste issues. Okay, we've got a committee meeting over here. But overriding all of this is there's a flood and we have to stay alive and we don't know when it's going to be over. Is there an overriding issue that you've pointed the group towards over the last several years that is sort of the floods will someday recede?
Well, there are two issues that come to mind, Tom. I'm not good at, you know, I'm a generalist, so I always think in more than one. John Eisenberg taught me to think in threes, but I'll come up with two quickly. So the first one is that this is not a new flood. This is a challenge this country has had since its founding, and that is the impact of racism and all other forms of discrimination on health outcomes and the opportunity for individuals and communities to achieve their potential in terms of health and well-being. And so I think that's another thing that our field, you know, while the field has done work on disparities research for decades, and we're part of the reason we understand that it's there and the various ways it expresses itself. Again, we have not done a good enough job figuring out how to improve equity in this country. And that's a whole other conversation. So I think that's one sort of constant flood or threat that our society has and that the field really needs to continue to do more on. And we've been pushing on that for several years, as Steve knows, and I'm really proud of that, but there's a lot more work to do. And then the other area, which is maybe more the coming flood, is innovation. I mean, Gen AI and Sora, my gosh, those videos are incredible. It's just, you know, this week's latest iteration of a mind-blowing advance in the way technology can change our world. And so if the field of health services research does not figure it that how to use these new tools effectively and safely with appropriate guardrails and all that, I mean, it's gonna eat our lunch, you know, like who are we? So I think that's, you know, and we're doing stuff about it, and lots of our field are stepping up. But I think those two came to mind right away when you talked about, you know, very important threats.
Got it. Thanks. That was good.
That's a good way actually to wrap it away, Lisa, because thoughts are like what to communicate for the next CEO. I think you just got it there. You're the future Noah. These are your principles. Go for, and then maybe find the third and complete the Eisenberg theorem.
Right,
So,
exactly.
So let's go off the record. Thank you so much, Lisa. We really appreciate this engagement.